Well, hello and welcome to another Sunday morning coffee with Dr. Childress here. So today I'm going to be discussing your therapists. Oh my goodness. The good, the bad, and the ugly. You're not likely to have a good one. You're likely to have a bad one, and some of you actually have really ugly kinds of therapists. The basic issue is they are ignorant, incompetent, and unethical, and that becomes a problem. They don't know what they're doing. So to start with, let's excuse me. Let's talk about the different roles of the therapist in your life. So you will have a family therapist, hopefully. That's your parent-child relationship therapist for you and the child. That's really the only therapist you need. The child does not have, is not crazy, doesn't need a therapist. The life around the child is a little crazy, the world and the family, but not the child. We don't need an individual therapist. But again, everybody doesn't know what they're doing, so they kind of flail about. The other is a forensic custody evaluator, and you do not want one of those. They are expensive and dangerous and harmful to children and lack scientific and legal value, and they're just really, really bad. And even afterwards, you will still need a diagnosis because diagnosis guides treatment, so they're pretty much irrelevant as well. So, I've talked about the custody evaluations elsewhere. They need to be ended in the family courts, but they're financially exploiting you. Uh, so now, what you want to do with your therapist is you'll want to get documentation on them, and because you'll either want to remove them or you want to elevate their standards of practice. Uh, the first bit of documentation you will want is their vita, their resume, and that's easy, typically or probably best acquired when you first start with them. So when you start with any mental health professional, just ask for their professional vita, and you can play ignorant on that. Oh my goodness, and it's so nice to meet you and stuff. Can I get your vita so I can just the other person that can ask for that is your attorney. Can ask for their vita. If you're going into court, you can say, "Oh, I'd like your vita for the court," or something like that. The moment you ask for their vita, though, you're going to make them really nervous because they're not competent, and that's what it's going to show. And so they're going to say, "Are you out to get me?" and stuff like that. And that's why therapists don't work in the family courts. It's too dangerous all over the place. So you've got the worst possible therapists because they're the only ones who will work in the family courts. So you will want their vita. That's for their standard 2.01 competence. And you want to look for competence in attachment and delusions based on their education, training, and experience. And you can run that through your AI. I've got an AI protocol up on my Substack and up on my website, but you can make one of your own. Just talk with the AI. You do when you're doing the Vita analysis, you don't care about all their publications. That's just an opinion, or about all their presentations. Opinion. They have an opinion, but standard 2.01 or the other competence standards for the other master's level professions are based on education, training, and experience received, not opinions given. And so I call them puffy Vitas. They do a lot of presentations and they write articles and they've captured a couple journals. And so they publish to journals their opinions about things. None of it's research. And so they have opinions. That's not competence. So that's what you're looking for: attachment and delusional thought disorders. Now, in addition, though, you will want a report from them. And typically that's going to be a treatment progress report. And then you may want their notes. Now, let me explain a little bit difference on getting their notes and getting their a report. If you get their notes, let's say you get their notes and you send them to me and I do a second opinion on their notes, they can kind of slide out of those because they say, well, I didn't discuss that, or I didn't discuss this, or this and that. And so those are notes. Now, they should have done a proper intake assessment. So that's what you want to be focused on their notes. What is their intake assessment? Did they assess for delusion? Did they assess for the attachment pathology, disorganized attachment? What's their treatment plan? The notes will likely not show, but they should show a treatment plan and their diagnosis. And those sorts of hard facts of diagnosis, treatment plan, and what they assessed for on their intake assessment should be documented. If it's not, that's a problem. But really, what you want to do is you want to get them up into writing a report, because then that establishes, now that's their voice, that's their diagnosis, that's their treatment plan, that's their thing. And mental health professionals will write a report at several key points. Intake, that's an intake report, intake assessment. Discharge, they write a discharge summary report. And anywhere in between is called a treatment progress report. And you can ask for a treatment progress report for the court or for your own informed consent, or they should be willing to provide that. That's if you go out into regular mental health services, ADHD, autism, something like that, it's no problem to provide a treatment progress update. And what that will typically show is how many sessions they met with them, when it began, and how many sessions, what the presenting problem was. Okay, so why did they come in? Court involved custody conflict, repair the child's relationship with the parent. Then the next would be the diagnosis and treatment plan. So the patient is diagnosed with such and such. It might go into a little history of symptoms, and then the treatment plan, and they will kind of order those up differently, but it's going to contain a little bit of background on the situation, family history, court legal history, something like that. Their treatment, their diagnosis, and their treatment plan for that. And now a lot of them, your therapist probably won't contain all that information because they're not competent. They don't know how to do stuff. You may also get pushback on their writing a report, because that's going to document that they don't know what they're doing. Okay, so you can kind of anticipate when you start to require competence, you're going to get pushback. You're going to induce a narcissistic injury. You're going to be exposing their incompetence. And so they can get dangerous, and they can write reports that you're being uncooperative with therapy and things. And so it's now that should never happen with your therapist. Your therapist should never be dangerous to you. But these therapists are, because they're so incredibly bad and incompetent, and nobody's enforcing ethical standards, and nobody cares. They've isolated you. So, so what you want is the diagnosis and the treatment plan. And what you'll be looking for is that the symptoms reported match the diagnostic criteria. Okay. And the diagnostic criteria you're looking for is a delusional disorder, fixed and false belief, maintained despite contrary evidence. In this case, it's a persecutory delusion that the child is being malevolently treated in some way. And so you get those symptoms should match the delusional disorder. If they've got the symptoms matching a delusion, that you're not abusive, but the other parents and making the child believe you are, then the diagnosis and the symptoms won't match. If there's no diagnosis, that's really bad, because then they're saying, bad for them, because they're saying there is no diagnosable pathology present. That if there was a delusional disorder, they would tell you, right? With your child, if the child was psychotic, they'd tell you. If there was child psychological abuse, they'd tell you. Spousal abuse, they'd tell you. But since they're not telling you, then that would mean there's nothing present. And there's not even a rule out, R/O. A rule out means that's still under consideration. So somebody might say, for out in the real world, they might say the child has a learning or ADHD is the diagnosis, and then you rule out learning disability. It means it's a possibility they're still being evaluated. And so the fact that there's no rule out delusional disorder, no rule out child abuse, no rule out spousal abuse would mean they are asserting that that's not even a possibility in this family. Because if it was a possibility, they would put it. And so that's another area that you can encourage your therapists and your mental health people to start diagnosing the pathology. Can you put it as a rule out? A rule out a possible persecutory delusion. And if it's a possibility, then yeah, they should put that on the form so that it alerts the court, it alerts the other professional, it gives your attorney some leverage on requesting a child protective response and those sorts of things. And so the quality of your mental health services really needs to go up a lot. It's so bad. And then you're going to want a treatment plan. They should have a treatment plan on that. And the treatment plan should have four components: the goals, the interventions, the timeframes, and most importantly, outcome measures. So those are the four things you want to look for in your treatment plan. Now, you can go to WikiHow. You Google WikiHow mental health treatment plan, and you get this page right here: how to write a mental health treatment plan. And so you can look at that, and that's what should be in their treatment plan. These 13 items that WikiHow lists, and part of its goals and interventions, timeframes for accomplishing those goals, and outcome measures. All of your therapies should have outcome measures. The individual therapist should have an outcome measure. They should have goals that they're treating. They should have interventions they're using and outcome measures to measure success and time frames. You shouldn't have 2-year therapies. The therapy should be about 3 to 6 months, for child therapy. If it goes for a year, I'm beginning to wonder what's going on. When I was clinical director, had my own clinic, I'd want therapy treatment plans to end at about 6 months. However, sometimes it goes longer. We have autism spectrum issues going on, or the crisis in the family is going on longer than that. But then the therapist would have to kind of justify why it's going on longer than 6 months. Department of Mental Health is kind of the same kind of attitude. They want to see a treatment plan that's going somewhere rather than just exploiting money. Insurance companies are kind of the same way. They want treatment plans and they want outcome measures. What are you doing? Now, the outcome measure can be something as simple as a SUDS, subjective units of distress. On a 1 to 10 scale, how depressed do you feel? On a 1 to 10 scale, how many times is a child acting out? And I'll give you a type of scale like that in a few seconds. It's called the Likert scale. On a 1 to 7 scale, how affectionate is a child? And that's what I recommend for an outcome measure. But every therapy should have an outcome measure. That's missing in the family courts because they don't know what they're doing. They're not going to be successful. So they definitely do not want to put an outcome measure that shows how unsuccessful they are. But to get competence, we need that to point out you're not being successful. And the reason they're not successful is they've misdiagnosed the problem. If you've accurately diagnosed the problem and you're effectively delivering the treatment for that problem, things are going to be fixed. There's only 2 causes for a failed therapy. Either you've misdiagnosed the pathology and you're treating cancer with insulin, or you're incompetent in delivery of the treatment intervention for that diagnosis. Because if you got an accurate diagnosis and you're competent in delivery of the intervention, things are going to get fixed. The problem with all these therapist people, your mental health people, is they've misdiagnosed the problem. It's not adjustment disorder. It's not anxiety thing. It is a persecutory thought disorder in the allied parent. The allied parent has a major psychiatric disorder, and they're inducing it in the child. That's child psychological abuse. The diagnosis we need to be treating is child abuse. Okay, that's the diagnosis, child abuse. We also have a spousal abuse diagnosis. We can put as a rule out maybe, but the primary diagnosis is the delusional disorder, factitious disorder imposed on another. We actually have two major psychiatric disorders that both lead to the child abuse diagnosis. The child abuse is a dangerous pathology. That's the one that's going to be guiding our treatment. Protect the child, stabilize the child, recover the healthy child. And so we have these background diagnoses that they're causing the child abuse in the allied parent, but our treatment plan is going to be focused on the child abuse diagnosis. That's why we need to stop using euphemisms. It's not parental alienation, it's not resist refuse, it's not parent-child contact problems. Those are euphemisms that cover up the diagnosis of child abuse, child psychological abuse by an allied parent who has a major psychiatric disorder. And that's what we need to be diagnosing and treating. So, outcome measures. What I recommend for outcome measures is a 1 to 7 rating scale. That's called a Likert scale, from none at all to a lot, and then the range in between. On 3 items: affection, cooperation, and social involvement. Okay, so every day, you as a targeted parent would rate your children on a targeted child on their affection, cooperation, social involvement on a 1 to 7 scale, and email that to your family therapist. Your family therapist would get those 3 numbers, put them in an Excel file, and begin to track their daily with you. Now, 3 or higher on a 1 to 7 scale, 3 or higher is normal range. That's what we're looking for. I don't care if they're 6s and 7s. Every now and then, that's fine. But basically, I just want the kid in the normal range, 3, 4, 5 or higher. Now, they can drop to 1s and 2s every now and then. That's fine. That's normal too. Just pop up the next day and stay basically normal range. I would consider a normal range week to be 5 successful days out of 7. So 5, 3 or higher ratings, and then maybe 1 or 2 a couple of times during the week. That would be a normal kind of week I would look at. If it's 4 and 3, no, that's not normal. Those are the symptoms of child abuse. And in the contingent visitation schedule, that's the rating scale we would use, and that's the criteria we would use on that. 5 out of successful days. These 3 symptoms, affection, cooperation, social involvement, are the symptoms of psychological child abuse. So let me tell you a little bit about treating abuse. Let's say we have physical abuse. I've worked with physical abuse, all the abuse. And so we got a physically abusive parent. The first thing is we protect the child. That's true of all abuse diagnoses: physical, sexual, neglect, psychological. We protect the child. So as soon as we get the abuse diagnosis, we separate the child from the abusive parent. The next thing we do is restore the child's healthy development, and then we restore with the abusive parent with enough safeguards in place to make sure the abuse doesn't resume. For physically abusive parents, the safeguards would be supervised parenting. We would also want that parent to be in collateral therapy and showing insight and developing insight as to how the abuse happens, so that we can reassure us, and we want reassurances from that therapist that they are developing insight. But for physical abuse, it's primarily supervised visitation on that. So, but with this pathology, psychological child abuse, it just goes right around supervision. You can put somebody in the room and all the manipulative stuff still happens because it's all so manipulative. It's under messages, it's undercurrents of things. And so while the separation, we need that for treatment related purposes, that's not going to be good as we restore with the abusive parent. What we're monitoring, though, are the symptoms of child abuse. So once we get the child away, we get the child back with the targeted parent, fix that relationship, then we're going to restore with the abusive allied parent. When we do that, we've got outcome measures of our time with the targeted parent that have the child in the normal range, affection, cooperation, social involvement. We want to see them stay stable. So once we restore with you, if the child stays 3, 4, 5, then that indicates that whatever's going on, the child's handling it. But if the child drops to 1s or 2s again, the moment we restore, that means the psychological abuse is coming back. We're seeing the symptoms of that pathology. And another reason why these symptoms, symptom ratings, and all of this is important is because when we do the treatment for the child abuse, we're going to pull the child over to the targeted parent. And it's a protective separation from the abusive parent because I've got an abuse diagnosis. And so we pull the child over to the targeted parent to fix with that. And typically, an olderish child, I will explain the treatment plan. And it is that we're going to recover with your mom or dad. Your mom, she loves you very much, and the professionals around you are concerned that your dad or mom is leading the family in problematic directions. Okay, and the family is just going from an intact family to a separated family where the parents live apart. And this is normal. This is a normal separated family. And then what we want to avoid, if there's too much conflict, it rips apart into a cutoff family. That's a problem, everybody. So we're worried about which parent is leading this family into a healthy separated family. And we believe that your mom or dad is leading this into a cutoff family that's problematic for you and everybody and things. So we're going to shift leadership over to your mom here because we believe she can lead this family into a healthy cutoff family or a healthy post-divorce family, whereas dad's going to do this. And so we kind of explain that developmentally appropriately to the child. And then say to the child, so and the child might go, no, I love my dad. He's so great. And I say, well, that's interesting, but it's the professional opinion of the therapist and the judge that your dad is leading this problematically or your mom is leading this problematically. And so we're going to shift leadership over to your other parent, your mom here. And what we'd like from you is to cooperate with us, cooperate with the treatment team, cooperate with your mom. And we're going to rate affection, cooperation, social involvement every day. All you got to do is be normal, 3 or higher, okay? And then not 1s or 2s. And when you come into therapy, we'll talk about incidents. We'll talk about the ratings and what's going on with that and make sure they're all valid and good. And that's what we're looking for. And fix any problems, communication problems, or anything that happen, any 1s or 2s, we'll fix those out. And so we're just looking for your cooperation on that. And once you get 3, 4, 5 or higher, that I'm fine. That's normal range. Now we restore with your dad, okay, who we think is a little problematic, but you're doing well. So that's all we care about. So we will restore with your dad. And when we do that, we just need you to stay normal. Okay, just 3, 4, 5. And this is the way you're going to be able to communicate to your treatment team what's going on for you, because without having to throw your dad or anybody under the bus here. So that if when we restore with your dad, if you just stay normal, then that's going to communicate to us that whatever's going on over there, you're handling it okay. Okay, because you're staying normal with your mom or the mom and dad. But if you having problems, okay, if they're getting a little problematic in their parenting and you have to collapse with your mom here and start showing 1s and 2s and doing all this problematic stuff, then that's going to indicate that you've had to collapse into your dad. Okay. So once we get moving forward here, we just want you to stay normal. Again, not sixes and sevens, just three, four, five, so that we can put this family back to normal, so that you're not caught in the middle. You can go on having sleepovers and getting on with your life and school and friends and all that stuff without being caught in all this kind of family stuff. Divorces happen all the time. They're fine. We just need a healthy, separated family where you're kind of holding the family together and shared between both parents. Um, and so that's what I would recommend sort of typically explaining to the child, and how you use the outcome ratings as part of the therapy. And then once we get the child abuse diagnosis on the allied parent, then if they start producing symptoms in the child, everybody's going to say it's the allied parent who's psychologically abusing the child, not you, the targeted parent, who's doing it. And so we undermine that whole manipulative thing. And so now, right now, if the child becomes symptomatic, everybody looks at the targeted parent and says, "What are you doing wrong?" Once we get an accurate diagnosis, it's not the targeted parent, it's the allied parent, then everybody goes, "You're abusing the child again." And now the allied parent doesn't want to be labeled the abusive parent. And we have the rating scales and we're asking the child to be normal. We take away all their motivation to create the pathology. It's not working anymore. It's called the functional behavioral analysis. We make it ineffective and inefficient in serving its functions. And so right now they get to spousally abuse you with the child symptoms, and they get to be the all wonderful parent. We redefine everything and remove their motivation. And with a factitious disorder, that's what you have to do on treatment, because as long as that parent's motivated to create pathology in the child, we're constantly swatting them back and trying to stop them. So we need to extract that motivation. That comes from the child abuse diagnosis. The moment we clarify that it's the allied parent who's causing the problems, and that it rises to the level of psychological child abuse, that's the accurate diagnosis that we need for the whole situation. So that's how outcome measures work with the treatment plan that's based on the diagnosis. It's an integrated thing, and that's what you should be getting, is that case conceptualization, the diagnosis, and the treatment plan from your therapist. And if they have any questions about that, they're more than happy. I'm more than happy to talk with them. They can get on my schedule and I'll consult with them about whatever's going on, and we'll come up with an accurate diagnosis and an effective treatment plan for that. I've put a lot of this stuff on the internet. They could just watch it if they want to. I have a booklet that tells them how to conduct the assessment for it. So you can give them this booklet. You can give them this booklet. Okay. And you can give them the narcissistic parent booklet. You can give them my book. Okay. And say, here's a description of it and all. And so I get the resources. They have it surrounding them. They just don't care to be competent. They don't care because it's effort. Oh my gosh, I have to learn what I'm doing. Yes, you do. But nobody enforces competence, so they just get to make up stuff and do whatever they want. Oh, it's just so bad. So, up on my website, in addition, now that's really easy. The outcome measure, I just explained it. 1 to 7, 3 items: affection, cooperation, social involvement. But I actually have a form up on my internet, on my consulting website. It's in the mental health consultation. I have the diagnostic checklist. I'll be getting back to that coming forward. It's a diagnostic checklist. Check, check, check. And you can actually make the diagnosis off of this. It's easy peasy. But then the parent-child relationship rating scale, and it's affection, cooperation, social involvement. And then I think I have the parent. There's a space for a fourth one if you want to. So that might be email contact or texting or calling with the allied parent or something like that. It gives you a little more flexibility. Affection, cooperate, and then there's some anchor points for that. But that's more formal. You can develop this informally 1 to 7, and then you go in and talk with the therapist every week about what those ratings are to do that. Now, I want to talk a little bit about your attitude when talking with the therapist. And this is deeply unfortunate that you have to worry about this, but you do because they're so bad. And so let me just say, they're going to register what's called your emotional tone or your emotional communication. So you have verbal communication, but it exists within emotional signaling, the emotional context. And there's basically 4 emotions that are going to serve as that context: angry, sad, afraid, and happy. There's 2 of those that are dominance emotions. That's angry, which is the power dominance, and afraid, which is submission. 2 of those are social emotions. That's happy, which is social bonding, and sad, which draws nurture. So we got 2 social emotions, 2 power emotions. Now, interestingly, happy, though, is also a power emotion. And the way that works is if I'm sitting around and with all my buddies and friends and everybody's happy, that means there's no predator threat. There's no danger in the world if everybody's happy. So happy communicates no danger or threat. So now, if that other parent, the allied parent, loads your child up with all these allegations and sends them over to you, and the child starts to challenge you for alpha dominance, and you can't tell me what to do, you can't take my phone away, you basically have 2 options from the old power system. You can assert your power, but now that's going to create fight with the child. So you're asserting angry, and they're asserting angry back into you, and you're going to get in a fight. The other is you go submissive, but then they're in charge and they're the ones in power. That's not good either. What I suggest you do is you bring over happy and make it a power emotion. And so when the child says, "You can't take my phone," you go, "What?" And you smile on it. Okay. When you smile, you drop a little happy chemical into your brain. And so you're emotionally signaling that that is no threat to your power. Okay. What? You don't want to do that. You think you're assertive enough that you don't have to follow court orders. And so you move into the happy emotion as the emotional signaling. And I suggest you do this with your therapist, is to monitor your background emotion. When you are asserting, like right now, I'm in a background emotion of angry. That's power, assertion, and voice. So if I'm doing power, assertion, and voice, I'm going to be here. Now, if I want to shift over to the background of happy, I just smile. And now I can say exactly the same thing, but you can hear the difference in my tone of voice because that little happy chemical relaxes some of the vocal things, the cadences, and I can keep it there if I keep smiling and I chuckle a little bit. I drop more in of the happy emotion, and so now I can assert stuff. If I go back to this, the power assertion and voice one, and say, well, why isn't it child psychological abuse? Anytime you assert, you're going to get pushback. That's just emotional signal of assertion is going to, don't tell me what to do. I'm the mental health person. But now if we soften it, so why isn't it child psychological abuse? We're communicating that social bonding underneath that the people say, oh, what a wonderful person. And you can say exactly the same thing. So listen to this. Let's say my son has a messy room, and I come in and say, Jack, this room is a pigsty. How many times have I told you to pick this up? What are you, some sort of animal? Versus, Jack, this room is a pigsty. How many times have I told you to pick this up? Well, what are you, some sort of animal? Same words, different tone, different way of being. So you can add the happy to the angry emotion, the assertion, say the same thing, but you're creating that social bonding. And so with the mental health people, that's what you want to watch out for is the power assertion and voice. You just drop happy on it, and you can assert, but you got the social bonding background to it. You also want to signal the other social emotion, the sadness, because that draws nurture. So if you, oh, I love my child so much and it hurts to be without them, and oh my goodness, and I want the best for them, that's going to trigger in the person, any person, a desire to nurture that. Oh my goodness, you poor thing. What's going on? What's happening? Especially for therapists, because that's what they've gotten the profession in for, is they want to be helpful to people. So they trigger on that. And what the child is signaling is anxiety, and that draws protection. I'm so scared of my mom, and oh, you poor thing, you're so scared. And so it's manipulative by the emotional signaling they're doing. For you, social emotions, you want to signal the happy emotion, um, so that it's a relaxed emotion. That's a social bonding emotion. Also, it signals to your child that you've got a handle on it. Everything's okay. You're not escalating up into the situation. Everything's okay. Everybody needs to relax on this. This is a trauma pathology. Everybody's up at the ceiling. We need to bring it down. Everything's okay. There's no abuse here. Everybody needs to calm down. Um, but you want to, with your child, you want to avoid the sad emotion, because that's going to draw the child's nurture of you. We don't particularly want that. You're going to need to guard against the anxiety emotion, because it's so contagious. And so the lie associated with anxiety is that, this is important. No, it's not. Relax. Everything's okay. No, this is really important. And so when you get anxious, you get up there and you start asserting into things, and because you're so important. Relax, take it down, smile on it, smile on it. When you smile on anxiety, if you're anxious and you smile, you change the emotion to excitement. That's your roller coaster. Ooh, this is scary and fun at the same time. And so it's a brain hack. You smile, you add a little happy chemical, and then you change the composition of what the emotion is. When you add happy to angry, if I'm in a background state of power assertion and voice, and I'm getting pushback on something because I'm pushing like this, when I add happy to power assertion and voice, I get leadership. Now I got social bonding and assertion. That's leadership. So you're changing the emotional context by changing the emotions that you assert. So that is just something to keep in mind with your therapist. You want to stay away from the anxious, because that's just going to elevate. And this is important, and by trying to calm you down. You want to, with your therapist, or with therapists, you want to signal your love, signal your hurt, signal your sadness, so that it draws nurture. But also the rest of the time, be in that happy state, that not mildly, on a 1 to 10 scale, it's zero point 0.5 to 0.2 max. Okay, you just keep it down low, but it's enough to signal to them, the social bonding, so they come out and join you rather than push back against you. So the the problem that you're facing is that your mental health people are incompetent. The patient should never need to explain the pathology to the doctor. That's just so bad. If somebody needs to explain it, I'll explain it. Give them my book. Tell them to contact me. Watch my videos. I should be explaining it to them, not you. Unfortunately, they're so ignorant, incompetent, and lazy that they don't bother to learn what the pathology is and how to fix it. And so here's the DSM-5 diagnoses that we're worried about: is a major psychiatric disorder in the allied parent, delusional disorder, factitious disorder imposed on another, that becomes child psychological abuse and spousal psychological abuse. We have 2 abuse diagnoses we need to be diagnosing and treating. Those are dangerous things. People are getting hurt. So one of the things you want to ask your therapist is, as you begin to shape them into understanding, oh God, that's so bad that you have to do that. But as you do that, you will want to know, why is it not a persecutory delusion? Now, here's a definition of a persecutory delusion from the American Psychiatric Association. Persecutory type: delusions that the person, or someone to whom the person is close, is being malevolently treated in some way. So that's The delusion is a fixed and false belief maintained despite contrary evidence. And so you're not abusive. The child believes you're abusive. Um, if you look at the BPRS, the criteria for full conviction is important. That kicks it into delusion. That would be acting as if the belief was true. Yes, the child acts as if the abuse is actually occurring, so it's delusional. It's an encapsulated delusion. It's just about this. It's not about a wide variety of things. It's encapsulated persecutory thought disorder, persecutory delusion. The primary case is in the parent. The child is a secondary case of induced or a shared persecutory delusion, a folie à deux. It's an induced delusional disorder. Parent is the primary case. That's the major psychiatric disorder. So as you're talking with the therapist, you're going, why isn't it? Dr. Childress says it's this, and so why? What criteria are missing? What would need to be there in order for this diagnosis to be the accurate one? What are we missing here that's not here? That the child doesn't believe it? That you think it's a true belief that I want to abuse my child and I'm malevolently treating the child? Well, let's put it on a treatment plan, fix it, and then everything should be fixed, right? Okay, and notice how I'm keeping in that happy tone, kind of, instead of assertive tone. And why don't we fix it? And you get pushback. But you need to be questioning like a fox, a little Socratic questioning, where you just keep questioning him, and they keep going down and having to defend these things that are indefensible. Then you also want to do it though with, why isn't this psychological child abuse? Explain that to me. Why isn't this psychological child abuse to be creating this such severe pathology in the child that's destroying their attachment bond to me? Tell me, explain, what would need to happen for this to become psychological child abuse? What criteria is missing? And then why isn't this spousal abuse of me? I love my child, and I've got this, narcissistic, dark, borderline parent who's psychologically abusing me by creating this pathology in my child. Why isn't that psychological abuse of me? Explain that to me. Okay, and that's you want to be happy, you want to do that, but you keep pressing them. Now, I've got YouTube's up there. I suggest you watch them so you know what you have available to you, but they can go watch the YouTubes on diagnosing attachment pathology, diagnosing delusional or persecutory delusion, diagnosing child abuse in the family courts, and what the DSM-5 diagnosis is in the family courts, plus a few others. So they can go watch these videos to learn what the pathology is. They're just too lazy to do it, and they just don't care. They're incompetent and lazy. I've also got a checklist that's up on my website, the attorney section, the attorney resource section, but you can freeze frame here and just copy it out. A checklist. So of the differential diagnosis. So is the targeted parent abusive? Yes, no. If yes, tell us why. If not, then is the allied parent abusive? Is the allied parent psychologically abusing the child by creating a shared induced persecutory delusion and a false factitious attachment pathology in the child? Yes or no? So you can give this to your therapist and just say, can you please answer this yes or no for me? And see what they say. And what they'll say is, no, I'm not going to tell you, which is insanely bad professional practice. Imagine going into your physician and saying, doctor, do I have cancer? And the doctor says, I'm not going to tell you. You're like, why am I coming to you if you're not going to tell me that my child is being abused by the other parent? They are simply abdicating their protective response for the child and for you. And it's so bad. And then you can break it down. Does a parent have a persecutory delusion? Is it shared? Is it a factitious attachment pathology? And is it spousal psychological abuse? Yes, no. Just tell me yes, no, so that we have clarity on things. But they will refuse to do that, because the moment they do, it becomes obvious that it's yes, that it is a delusional disorder, that it is child psychological abuse, and that we should be protecting the child. But they simply won't protect the child. They don't do it. They do not protect children from child abuse, which drives me crazy. So here's the situation we're looking at. Everyone else in healthcare gets diagnosis and treatment. You get forensic custody evaluations that are financial exploitation, no diagnosis, no solution, and destroyed lives. So first thing we need to do systemically is get rid of the forensic custody evaluations, stop them, and get everybody back over to diagnosis and treatment so we can start protecting the children and their parents. The problem is called institutional betrayal. This is a seminal article on this from Smith and Freud. Freud has a Center for Institutional Courage right now, talks about institutional betrayal and institutional betrayal trauma. This is from the journal American Psychologist, the flagship journal of the APA. So we know that what's going on, that institutional betrayal by the mental health people. And so until we fix that, until we solve the systems problem, where the institutional betrayal and regulatory capture, there's no solution for you because they just give you one thing, a custody evaluation. Can you get a clinical diagnostic assessment? No, you cannot. They refuse to diagnose the pathology. They refuse to diagnose the child abuse. They refuse to protect your children. The moment they start to diagnose the child abuse, then they admit they haven't done that for 40 years. The moment they stop the forensic custody evaluations and return to clinical diagnosis, they admit that they've been experimenting on you and it's a failed experiment for 40 years. And oh my gosh, the class action lawsuits open up, the scandals open up. AI's estimating over the 40 years is between 300,000 to 1.5 million abused children who have not been diagnosed in the family courts. And you can do that, work it up with your AI. I've got a blog on it. And so it's coming. The scandal is coming. The moment we stop the forensic custody evaluations, you can look at any VITA, run it through an AI, attachment, competence and attachment. This is an attachment pathology, child rejecting a parent, competence and delusional thought disorders. That's a differential diagnosis. None of them have it. They are universally practicing beyond the boundaries of their competence. All of them. Because they don't care, because of the institutional betrayal and regulatory capture. So with that, I'm going to head off to the rest of my Sunday. Good luck for you dealing with your therapist. I will say again, there is no solution for any single parent until there becomes a solution for all parents, until we correct the failed institutional betrayal, until we get you competent mental health services who will diagnose a child abuse and protect your children. If we do not start protecting children from child abuse, guess what? Children will be abused. They are withholding clinical diagnostic assessments. They are withholding diagnoses of child abuse from you, from the court's understanding, from your attorney. If they diagnose a child abuse, your attorney can go in and argue for a protective response. But they're not diagnosing the child abuse, thereby giving the advantage to the abusive parent to continue to manipulate the situation, and because they are covering up for the abuse. The mental health people are covering up the abuse by not identifying it. The moment they identify it, the cover up for the last 40 years will become blatantly evident. And it goes to the APA, it goes to your licensing boards. So with that, good luck to everybody out there. I'm willing to talk to anybody, so you can just tell them to talk to me and get them on my schedule, and I'll help them understand the situation. So with that, I'm off to my Sunday. Take care, everybody.